people for doctors. And with that, so today we have a number of speakers, very well-known speakers. And before we go to them, I will request our Honorable Vice Chancellor, Professor Dr. Shoikat Moitro, to inaugurate this session and today's session, and then we will proceed further. Sir, please.
Okay, thank you, Dr. Dasgupta. So this is series 3 under the Resurrecting the Emerging Contours of Public Health in Anthropocene, the Urgency of Digital Health Revolution. And we got a very good response from the participants and our community, learning community, for this webinar program. So we have taken an initiative for introducing a digital health program in the form of either in the form of training or research or other academic activities from this university very soon. We have decided as a part of our agenda or mandate from the university that we will be initiating these types of programs under a Center of Digital Health, and that we have declared earlier that has been a documented policy, and with that agenda we are organizing these types of webinar one after another for generating more and more awareness about this activity at this university. There are two aspects. One is digital health itself. This subject is not so, not so structured or not so organized in a manner that many of the academic institutes or universities so far, they have not yet introduced structured programs in digital health. But it is evolving. It is evolving, and it is taking care of different development which has happened in the domain of information science, in the domain of electronic science, in the domain of medical science, and related areas, social science and related areas, and it is evolving as a subject itself. Maybe within a shortest period of time, it will emerge as a very well-structured program. We'll be working in that direction with the emergence of artificial intelligence, Internet of Things, with the emergence of data science, with the emergence of data analytics, with the emergence of different electronic gadgets, sensors, and medical in the different these features of medical science, then analytics in health and other areas. We are this now this is felt the urge. This is now felt a necessity among the stakeholders of these public health systems or medical research systems or allied research systems to make an integration of all this knowledge of evolved knowledge and all these verticals in a manner such that this near future the requirement of professionals for handling these things in a meaningful way, in an effective way, that can be managed, because in our country we need lots of this technology-based intervention in healthcare system, and that is required to give access to the millions of underprivileged people to the quality healthcare. By and large, in India, we have a disparity at many places in the form of this quality medical healthcare system is not available. But using technology now, it may be possible. It may be possible and formidable also to provide these types of facility to these needy people at different parts of this country. And with that, we have planned to make an arrangement where experts from different fields will be at our system, and they will be engaged in designing the entire academic plan, and in bringing more resources in this area, and to generate different types of programs, training programs, research programs, and other allied activities. Maybe in the future we can have structure this academic programs in the form of certification, in the form of diploma, in the form of postgraduate diploma, in the form of degree. It will take it may take some time to offer a full-fledged degree or postgraduate degree in this area. But immediately we can start some agile programs like certifications and diploma and all these things. And that is very much possible because there have been enough resources available now to start with these types of programs. And government of India and with different state governments have taken, in our state government also, they have taken an initiative in making this digital health effective and functional in the state, in the country. And we are seeing that this emergence of telemedicines and different types of these facilities and all these things are being created by government. And now we need to involve in these systems in a more effective way. And from the university side, it is our primary responsibility to generate a quality human resource for handling all these things. Researchers have been there in many areas. We have seen that different these information technology based organizations, researches are being conducted in healthcare and all these things. In medical science also, medical practitioners, they want to understand this nitty-gritty and all these things of this technology and how to make this technology useful for their purposes in a better way. And for that purpose, we need to carry on research further for developing some indigenous solution for our systems. Most of these things, most of these, these gadgets, most of these softwares, most of these tools, these are still being, these imported wearables and all these things still being imported. We need to this design and develop these types of systems at this country. This is also the mandate of Government of India, Make in India and all these things. And because you see, there will be huge numbers of requirement for wearables. And that is mostly being imported from other countries. And because of this rearrangement of the geopolitical scenario, now maybe there will be restriction on imports on many items. But to take up the situation, to handle the situation, we need to generate a large number of entrepreneurs in this field. And to train this entrepreneur, we need to have a center where these types of resources, expertise, training, and all these facilities will be available. So this is our planning. Our planning is to, from these centers, we will have collaborative research, we will have structured academic training program, certification programs, and degree offering programs. We will have training program for entrepreneurs. We will have consultancy solution for different, the systems. In this way, we will try to build up these centers, and maybe in near future, we can establish it as a center of excellence in this domain of digital health and allied areas. So this is our basic and initial planning, and this will be in line with the government declared policy and all of the latest development which has happened worldwide. And we are going to have collaboration and networking with different organizations, government organizations, professional organizations, IT organizations, medical organizations, either at the state, at this country, or from other states, other countries. That is our this planning. We'll have collaboration, agreements, networking, and all these things. At our this board or at our system for managing all these things, we are right now having numbers of experts in their own fields. We have Dr. Pranta Chakraborty. He is a very famous medical practitioners, and with us with significant knowledge in this particular area. He will be one of our key person. We have with us Dr. Pradeep Mitra as an advisor, who is a well-renowned medical practitioner and health professional. Then we are having Dr. Debashish Bhattacharya, probably who is the Director of Medical Education. We are having some persons from other medical these sectors like Dr. Sujit Korporokastho, Dr. Subhrajyoti Bhaumik. I do not know whether he is here or not. Maybe he is here. And from our side, Dr. Dasgupta is here. We are having some persons from pharmaceutical background. Professor Pranabesh Chakraborty, he has joined us to head this pharmaceutical and food science department. He will be a part of these things. Some engineers like Professor Dr. Ananta Kumar Das, scientists like Dr. Sarojini Chakraborty, Professor Anjan Dasgupta, all of them will be advisor or this in different capacity. They will be serving this system right now, and slowly, not slowly, rapidly and quickly, it will be my expectation. It will evolve as a well-defined center with the numbers of expertise available with it for serving the society, for serving the community. And with this expectation, let me conclude and let me hear from these experts who have assembled here. All of them are doyens in their subjects, so they will have their own planning. After all, we will after all these things, we will try to develop our own policy documents for this center itself. How to run this center for maybe next 6 months, 1 year, 2 years, or 5 years in this way. So we will make these milestones and all these things, and accordingly we will allocate resources. We will allocate budget for running this center, and it is definitely our agenda mandate. And maybe within few years, within limited period of time, this center will be a center of attraction for for all these budding professionals or who want to carry out researches or academic activities in this interdisciplinary area. Thank you.
Thank you, sir, for these inspiring words, and we look forward to a real center of excellence in digital and health and allied sciences. And today we have
one thing I have forgotten. Initially, though our main campus at Horinkata, but we have decided to start this activity from Calcutta itself. We have some establishment at Calcutta, and there we are having some setup at Salt Lake, and we are going to acquire other these buildings and assets at Calcutta itself. Whatever it is, we want to make it Calcutta based so that persons can get more this time for accessing this center, for spending more time there, avoiding this traveling time and all these things. Maybe in near future, when this becomes mature, then we can think of shifting some of the activities at Horinkata campus. Right now, we will be focusing at our Calcutta center for running this activity. Today, we will decide the date of inauguration of this formally. After all these things happens, then we will arrange maybe for virtual inauguration of these centers. We will make video documentation and all these things, and that will be a very interesting feature, and that will give that we want to give that proper publicity for making it this information available to the general mass, so that people can take more interest in this activity. And maybe within next week we can plan a suitable date for that. I will request Professor Sarojini Chakraborty, Dr. Dasgupta, Dr. Pranta Chakraborty kindly decide on that, so that we can make a proper preparation, take a proper preparation to make this inaugural program a successful this event and within the next week. Thank you.
Thank you, sir, for further information, and we look forward to the grand inauguration of this facility. And today we have with us renowned professor of Calcutta University, Professor Anjan Dasgupta, and renowned Dr. Pradeep Mitra, and of course renowned Dr. Pranta Chakraborty, who has already been introduced earlier, and he has already
Dr. Anjan Dasgupta is with us. He is not a newcomer. He is already with us. I am seeing him for the last 4 years. He is associated with our biotechnology and bioinformatics program. So he is insider.
Okay, right. So, but they are
formally, correct, Dr. Professor Dasgupta.
Yeah, no, that is okay. But formally, he has informed us that he is still with Kolkata University, associated with Kolkata University.
I do not know why
but, equally from now onwards, he is associated with us. So he is included in our team. So I think he is with MAKAUT. Okay.
Yes, yes,
Now,
yes.
before we go to our honorable speakers today, and I would like to request the coordinator of this program, Dr. Sharadindu Chakraborty, to say a few words, and then we will go for this
No, let
presentations.
me welcome Dr. Pradeep Mitra.
Yeah.
We have this long time connected, and nice to see you there.
Thank you. Thank you.
Good evening, sir.
Good evening.
Okay, thank you, Shivam. Hello,
Please.
a very nice evening to everybody, and greetings to all the distinguished dignitaries and participants. We are indeed proud to host the third and final lecture of our 3-day webinar series under the broad theme, Resurrecting the Emerging Contours of Public Health in Anthropocene, the Urgency of Digital Health Revolution. This is a joint initiative of two wings of MAKAUT, the Biomedical Engineering and Health Informatics Group, in association with the Department of Environmental Science. This webinar series is actually a tribute to the famous British health reformer, Florence Nightingale, popularly reckoned as the Lady with the Lamp, who is regarded as the forerunner and founder of modern school of nursing. She was born exactly 200 years back in 1820. So this year, 2020, we are passing through her bicentenary birth year. But the actual fact is, which very few people know, that Florence was also a great scholar of health statistics, which she developed by choice. She wrote a number of useful books and memoirs on health data conceptualization, visualization, documentation. Of course, modeling was not there at that time, but she made good use of pictorial and graphical representations of statistical health data in form of infographics. Today, we are speaking of many new subjects: environmental health, geohealth, geophysiology, biomedical engineering, and many more. But the founding pillars of these new emerging domains stems and owe a lot to the Nightingale vision, Nightingale effect, and Nightingale ethics. Such a webinar was thus the absolute need of the hour, for which I must express my gratitude to our most reverend Vice Chancellor, Sir, Professor Shoikat Moitro, who always inspire us to the tenets of deep ecology, ecosophy, eco-pedagogy, and green praxis. So this Nightingale bicentenary year is the most befitting and golden moment to launch the new Center of Digital Health, as announced by our Vice Chancellor, Sir. Today, we have with us three eminent speakers in our panel. First, Dr. Anjan Dasgupta, an eminent biophysicist and UGC professor of biochemistry, University of Calcutta, who will speak on a conducted data tour in the digital health domain. The second presentation will be made by our highly honored and decorated Dr. Professor Pradeep Mitra, former Director of Medical Education and Secretary to Department of Health and Family Welfare, and presently Head of COVID Monitoring Task Force, Government of West Bengal. I once again reiterate, Dr. Pradeep Mitra is presently the Head of COVID Monitoring Task Force, Government of West Bengal. So we are curious to raise many questions for Dr. Mitra, and we wish many answers from him. After the first two lectures, there will be a grand summing up session as takeaways of this seminar series by none other than Professor Panta Chakraborty, former head of hematology, NRS Medical College, and advisor to frontline hospitals of Kolkata like Fortis, Nightingale, Apex, and Vivekananda Institute of Medical Science. He is also a distinguished member of several key committees at state and central levels. Incidentally, both Dr. Pradeep Mitra and Dr. Panta Chakraborty are cardinal members of our biomedical and digital health group of MAKAUT. We are indeed passing through a trauma of conflicting realities, as if we are standing at the end of a precipice with bell of Bethos ringing nearby. Who is inimical to whom, or whether I am against myself? How far is the zenith, or how deep is the nadir? What will be the precision of mutation are endless issues that is difficult to resolve by simple, mere chemical prescriptions. The potential core needs to be fathomed and controlled by some form of metrics on infections and mortality. The end game can only be cited if these metrics of infection and mortality are brought down below the cutoff point. Ramchandra Guho, in his recent article, where the
আমি স্ক্রিন শেয়ার চাইবো আর কি আমার
has
প্রেজেন্টেশনটার আগে
rightly urged for composing an
আমি তো শেয়ার
international patriotic song to embrace global COVID sufferings, and has strongly advocated for the principles of reductionism and integrated knowledge building approach, where sum of parts will always be greater than the whole. A wonderful suggestion from him indeed. The present restrictive situation leads us back to the fairy tales of Alice in Wonderland, where Lewis Carroll nicely sums up the secret to human existence by saying, we are moving faster and faster in order to remain standstill. To survive every tomorrow, we must learn to run as fast as we can. And if we wish to get something more, we must run twice faster than before. So to kill the virulent virus, we have to run very fast, very hard to co-evolve with the natural system, lest we perish in penury. So let us all wait for the divine ray and the drop of golden sun to bless us for the long, long way to run. Thank you all, and over to Shivama sir to continue, please.
Okay,
Thank
so
you,
I'd
Dr.
like to add some anecdote. So that's Alice in Wonderland. That is a great book of management too. There is an incident where Alice is asking the cat sitting on the tree, can you suggest me which road I need to take? The cat replied, where do you want to go? Alice replied, I do not know. Then the cat replied, then it doesn't matter. So this is very important thing in that sense. Here we decided the road which we can take. So at least we can answer. We can take the road to reach the center of excellence in digital health. So that is an anecdote for this story. Alice in Wonderland. Thank you.
Thank you, sir.
Thank you, sir.
Dr.
Thank you, sir.
Chakraborty, for such a wonderful, orientation, speech. And I would now, although Dr. Dasgupta, Anjan Kumar Dasgupta, actually is renowned professor, he needs no introduction, but it is necessary. It's a formal custom that we introduce the speaker. Dr. Anjan Kumar Dasgupta retired as a UGC open post professor from the Department of Biochemistry of University of Calcutta in the year 2017. He is presently an ICMR principal investigator, DBT principal investigator, MEITY co-principal investigator, and he in Calcutta University. He passed MSc Physics from IIT Madras in the year 1978, then obtained his PhD from University of Calcutta in the year 1983. He has proven track record of initiating new courses and projects in both the universities he was associated with, University of Kolkata and University of Calcutta. And he contributed in a major way towards teaching, research, and inventions. Now, from now onwards, he is also associated or involved with MAKAUT, as our Honorable Vice Chancellor has already said. So we are also introducing him as part of our MAKAUT. And over to Professor Anjan Dasgupta to deliver his speech. Sir, please initiate your slides and speech.
Can I start? Should I start?
Yes, yes, please.
Yeah. Good afternoon to respected Vice Chancellor, Dr. Sharadendu, Dr. Shivamaya Dasgupta, and Professor Pranta Chakraborty, Dr. Pradeep Mitra. And I am honored to be part of this program. And let me just point out that in MAKAUT, there was a very interesting seminar on big data, in which I was a speaker, and I really remember that, in which probably Sharadendu was also an organizer to that, and I actually I'm somewhere in between. Because of the distance, I could not join and take regular classes in MAKAUT, but I like to contribute anyway, because I remember the very inspiring discussion I had with the Vice Chancellor regarding the big data induced new changes which in health sciences. We had a very small discussion though, but we had long back. Now, let me start with the slides. Just one small comment I would like to make. If you want to go somewhere, you have to run twice faster. It was by Mark Twain, sure, not by Lewis Carroll. Okay, coming to, so why it's not shared? Okay, share the screen. So is it
Yeah, it's coming.
visible now?
It's coming. You're not yet come.
So this is this. So this is
Yeah,
the
it's not,
title
yes,
of my
yes.
talk.
Yeah.
Conducted to
Conducted to, yeah.
this is the conducted to. So
Yeah.
so let's think in a very brief way that what is the future now? Right now we are in a, as we are in a very transient type of world where we have to think how we will plan our future. And it's very inspiring. The right things are being done, and I think this I'd be very happy if this present sessions become a springboard for that. And so we have to have what is called open innovations. We have to know what is the unexpected lessons from this kind of unprecedented crisis. And we have to keep the innovation projects going over distance. So these are the things which we should understand through the crisis, because unless we keep these innovation projects from distance, this whole thing not starts. We have projects which will be remotely done to some extent at least, and this probably will be the future of the healthcare and medical technology. So now, how to re-architect? We have this basically small part of this re-architecture is crisis proof. Make it crisis proof, so that we have to design the whole architecture in such a way that it doesn't fall down like this. Sometimes it falls down, so we will develop a kind of what is called fail-safe technology. And then, how will medical care approach risk as pandemic settles down? This is important thing. Smart biomedical investment strategies during the pandemic. What priorities must change and what must stay the same? These are the important issues which you should consider. Now, before 1999, we had something called e-commerce, e-business, and e-solutions. Many of these companies which we know, like this Flipkart, Infosys, this contract people were sometimes called in an abusive way, called the info coolies. They came out because all these e-business, e-solutions, e-commerce are basically, they are based on contracts from abroad and things, but they flourished very well. India became a software giant because of them. Now, after 2000, we have a new paradigms, what is called e-health, e-agriculture, and then we have e-environment. These are the three things which are very important. And I'm sure that today, basically, I think we are emphasizing more on e-health, but with this, I just point out that e-agriculture, e-environment are also coming in a big way. So component of e-health. I think so those who attended the last two seminars, these were very nicely discussed. What are the components? But still, I thought I would like to have a very short summarization of this e-health business. And these are the things which I would give some emphasis to. One is called telemedicine. One is health informatics. One is mobile health. And other is evidence-based medicine, or EBM. Since because of my teaching experience, I know that we need to have a kind of very abridged version of overview of all these things, because it's a very complex subject. But while it is a very complex subject, we should know what are the different components in a very, very simple way. So these are the four components which I thought very important, particularly if we want to have a kind of syllabus for this kind of e-health. I think this kind of what is called focal nodes are very important. And now, what is telemedicine? Telemedicine basically is how you capture readings from the medical devices at a faraway location. And using telemedicine software, patients can see a doctor for diagnosis and for treatment without having to wait for an appointment. Then patient can consult a physician at the comfort of their home. And this is one of the sites which is very interesting, which you can share from. I'll anyway put the whole thing in the GitHub and you can see it. Now, these are the telemedicine companies which have come: Teladoc, MEMD, iClinic, Amwell, PlushCare, HealthTap, Takeway. And there is an Indian company, though I think it is a kind of some branched, there's a branch, it's a branch of a foreign company, but it is there in India also. Now, I'll omit this for the time being. And these are more detail about the mobile health. But if time permits, I'll come to this in a little more detail. But since I have already been told that there is some shortage of time, only thing I want to mention in this mobile health business is this is one part which is highly underutilized, very, very underutilized. There are lots of possibilities, but this particular paper, which is there with me, and which you can see from my shared folder, this particular paper gives a very nice account of that. And there's something called EBM, or evidence-based medicine. This evidence-based medicine uses the current data science-based approach in decision making. And EBM integrates clinical experience and patient values with the best available research information. So this paper gives a very nice account of EBM. And again, if possible, I'll give a tour of this particular site, and I'll tell something more if we get time. And this is what is called trend inspection. So I think while talking about the big data last time, we talked about a little bit of trending, because we have very nice R-based or even Google-based platforms for trend inspections. And you can see that any particular give a keyword, it will tell you that this is something like is going up and is going down, like that. So this is how we inspect the trends of different things, the terms I was mentioning. For example, evidence-based medicine. This is health informatics, mobile health, and telemedicine. And then see who is in the top. You see telemedicine in the top. See here. Telemedicine is coming in a very, very big way. So telemedicine, and you see the time. You see the time here. That's very interesting. It is a time where we have the COVID outbreak. So this is from the Google and our platform search database, where you see just after COVID, there's a shooting up of the interest and search hits of telemedicine. And this is very interesting. This is something which I would draw the attention of the data scientists. This is the time where you had this is the time where you had the COVID outbreak, and you see the data scientists, data science searches and COVID searches, I mean, the telemedicine searches, they're complementary, as if some data scientists are going into the telemedicine. So this overlap is very interesting because probably because of the confinement, many data scientists could not go to the office, but they thought about contributing in this definitely, because that's why there is a surge here. So I just write an equation like this. I was inspired by the last few speakers in this health session, which they also use very interesting question. The e-health is a very simple combination of ICT and DS, that is information and communication technology and data science. The ICT involves what our Honorable VC was mentioning, IoT, sensing devices, smart material technology, whereas data science involves all the computational parts. This simple equation summarizes what exactly e-health is all about, because it is a union of two very, very emerging sets, data science and ICT technology. So this is probably true for environment and agricultural use also. Now, this is Moore's law in healthcare. All of us are aware of this Moore's law, which states that the number of transistors on a microchip doubles about every 2 years, though the cost of the computers is halved. Now, Kurzweil said that the year 2029 is consistent date that our AI will pass a valid Turing test. That is, the artificial intelligence will beat the human intelligence or become equal to the intelligence. This is a kind of, sometimes it's called Kurzweil singularity. This is a time where probably we'll have a very big diffusion of AI in the healthcare. So that is very good for e-health, because more AI comes in this e-health, it will be more versatile. Now, so this is called Newton's first law applied to manufacturing and society. So sometimes some things continue to advance, and you can see that this particular, there is some small change which is happening here. It is going down, size is going down, and then actually you can see that actually there's some it's going up also, because now you are having big smartphones also. But you can see there is a change in size when there is evolution, and that will happen for this medical and e-health also. And this is about the other part of the e-health, that is the modeling part. We have what is called two classes of modeling. One is called SDM, Systems Dynamics Modeling, and the other is System Dynamics Modeling, and this is called ABM, Agent-Based Modeling. Those are who are used to this agent-based models. They may be interested, because this is a very interesting part of modeling.
Government permission kar dein. Na, देयনি government kar.
This SDM simulates movement of entities of the system behavior, and they can interpret making the flow of water out of the bathtub. And ABM, so basically SDM is something like community health, and ABM is basically a ground up representation system, which is something like modeling the personalized medicine part. So if I in a global perspective of e-health is community medicine and personalized medicine. So this kind of SDM model for ABM type of modeling is for personalized medicine. Both are important. So I'll skip it because of time, as I said. That can AI ever beat the doctor? I'll just mention about the famous debate between Roger Penrose and Stephen Hawking, where there's a competition between human brain and computer. And Penrose always said that human brain will be always superior to the computer. But this debate was very interesting. This debate was basically about something like your Kurzweil singularity, that they are competing. Nowadays, they are almost competing. So this e-health will see a competition between the e-doctors and doctors. And so it is important for us to realize that the future of our medical science probably lies in somewhere in the superposition of these two communities, intelligent who are doing AI and medicine. Now, I'll just divert a little bit. What are data that are available? What is the database which are available here? So you can see here that everyone has a number of data. I'm sorry that you cannot see it, but I'm just telling you this cancer database is there, stroke database is there. There is a CVD database, and then diabetes, ICMR. So these are the different databases. But if you see the records, these records are not very impressive. It is only in, for example, typically only 58,000 records are there. And since December 1st, this prescription upload is about 1,000. Lab reports uploaded is about 1 lakh. So these are not very impressive. Now with the e-health upsurge, I'm sure that these records will change drastically. Now, this is again a system diagram where you have, this is called what is called the capture. This is the what is called the capture. This is the process. This is the maintenance. This is the communications, and this is the analysis. So this maintenance part is very important because you need some domain experts like a doctor who will probably integrate the capture, the process, the analysis, the communication, or everything. So this is how this is what we call the life cycle of the health data. So I'll skip this part and then SDM. So it's taking a little bit because I think it was there. So here I am giving, this is from the film Parash Pathar by Satyajit Ray, where he says, I'm just speaking Bengali, I think most of us understand Bengali. So this is basically data everywhere. Data is everywhere. You have to know how to capture data. You should know the art of processing. So this particular thing is important, that although data is everywhere, we should know how to extract data, how to extract meaningful data, how to make it profitable. So, I'll just have a quote from Nick Dawson. The least e-health can do. Aravind Eye Hospital in India does more eye surgeries than any other place in the world. Do we know this? We don't know. It treats nearly 2 million patients a year for remarkably less than most of the hospitals in the United States. And it treats nearly 2/3 of these patients for free. Now, this person, Nick Dawson, says, if my Yelp app on my iPhone tells me that FedEx can get a raw fish to Aspen, we can surely get the blind to India. So the least thing e-health can do is, it can share the information that, well, you see, Arvind Eye, there is a hospital called Arvind Eye Hospital in India. Who does it? We don't share the information. Even in Calcutta, there are many interesting organizations who does a lot of things, but we don't know. So this information sharing is a very, very important part of e-health. And I'll just say, pulling the COVID data, how to pull the data. So this is one part which is which we did a little bit of analysis from using a platform, simple platform. You can see here, if you take the confirmed case, which is in red, and recovered case, which is in the blue, and x-axis is the number of tests, you can see here, the confirmed cases, the recovered cases show a very, very systematic profile. You see in the yellow. But here you see if you see the confirmed cases, in this area, when the tests are less, there is a confusion zone. That is, some people are saying that there's a small number of confirmed cases, and there's a large number of. So there's a kind of bistable system here. Although this bistability is not the actual bistability, is basically it is bistability caused by confusion of the test itself. So when tests are more, why people are saying that more tests, more tests, more tests? Because when it exceeds this particular zone, when it comes to this zone, then you can see here there is a no bistable nature. There is this kind of confusion zone is not there. So higher is the test, you have lesser confusion in this area. This is just a analogy with the bistability, what bistability is. And this is another very interesting thing. If you see, this is confirmed case and this is recovered case. Okay, x-axis is confirmed. So this is confirmed, this is confirmed, and this is recovered. And you see here, there's a delay. Why this is delay? Because actually these are the things, small things which are not normally considered in most of the models. That's why there is a delay. The delay probably is because you need some time for recovery. It's not that a magic. Biological system is not magic. Medical health is not magic. So you need some kind of help. So this is again a data pooling where you have all the data from different countries put together, and you can see who is in the top. The United States is in the top. So they are the superpower. So there's the top in the number of infected cases also. And you can see this is one very interesting thing. This is the effect of the lockdown. If you see that after the lockdown, if you see deaths per confirmed, you see after this period, the slight death per confirmed has gone down a little bit in India. This is the very important and interesting model. It's called SIR model. When anyone talks about epidemiological outbreak, they talked about SIR model. And what is that model? Model is based on SIR, suspected, infected, and recovered. So this model is a very simple differential equation set. And I'll not get into the heart of that. So I'll just show you how it is solved, and I'll not get into this also, but I'll just show you how it looks like. You can see here, susceptible is going down, infected going up, recovered going up. Infected shows a kind of upsurge and then down. So infected shows a kind of bell-shaped curve. So this is how it looks like. The model is like this. Now I'll again skip a lot of details because there are a lot of other details. This is the SIR model with different cities connected. So there are some papers which shows how different cities will be showing. And there's one interesting feature you can see here. They already predicted that this Mumbai will have a very high. You see here, because Mumbai is more connected. So this you can see here that higher occurrence of this in Mumbai was predicted by this model. So just by making SIR model, modification of SIR model, they could predict that certain cities will be having very high upsurge as compared to other cities. I'll not get into the detail as because of time again. So there is a modification of SIR which is called SCIR, where you have suspected, exposed, infected, and recovered. And this model is something like this. You have DSDT is this, DDT is this, DIDT is this, DRD. So this particular model has, I'll just get into the solution of this. You can see here that unlike the SIR model where the infected shows a curve like the black one, here the infected sustains for a long time, SCIR model. So there's a high infected population for a long time in the SCIR model. And these are solutions, mathematical solutions of this. And I'll not again, I'll just skip this part. And the ICMR model, by the way, is based on SIR. The ICMR model this ICMR model, which is based on ACIR. But ICMR is not happy with the model because ICMR says that these models are not good, because the problem is the modeling are not considering the meaning of the, they are not able to explain many of the sin. That doesn't mean the model itself is bad. That means the model needs modification. This is the famous controversial model, University of Michigan, and I think this is not a controversial one. This is dynamics, economics policy, CDDP. This is the which predicted, one Indian was there, who predicted millions will die and all that. This party is basically based on, by the way, ABM, which I mentioned, agent-based models. But these simpler models like CIR and SIR, they could explain much better than the advanced models like agent-based models. This is one thing I want to discuss, because sometimes data-driven discovery and model-driven discoveries, these are two different aspects, because in one case you are having the mechanism in mind and then you predict something, and in one case you have data and you try to explain. The problem with the database discoveries is that data may bias you actually. The data actually may bias you. So, so these are the summary of this models, ABM model, and there is a Cambridge University model which is also based on SAR. I'll not, again, I'll skip this. Okay, just one small thing is here. I just want to mention something here. We talked about these problems with these models because most of these models did not have this bistable nature. Here I'm explaining what bistability is. You see, these two infected and suspected this is infected, this is susceptible, and they cross here. That means there's only one steady state. But in this case, you can see here there are three steady states. One is crossing here, and crossing here. In this case, you can see this is a stable state. This one and this one. This is stable because you can see both are, this is attractor. And here also you have one stable state. And here you have another stable state here up. But here this particular thing is unstable state. So this is kind of unstable. You see here this is unstable. So this table is unstable. So this state, unstable state caught between two stable states. Here also you have a stability. So you have a parameter change. You have stable, then stable, unstable, stable, and then stable. So these are the things which are called bistable systems. So bistable systems show this kind of sudden and unexplained instability in the between. After this, I will rapidly come to another very interesting aspect of e-health, that is where you have a very nice combination of what is called data and technology. So ECG is one of them. I'll not get into the detail of this. I'll just say that there is a site called PhysioNet, which gives a very, sorry for this, PhysioNet, which gives a very nice account of this data. And I'll skip, and I'll, if possible, if time permits, I'll come to this after this. So I'll again briefly discuss what is called the ECG. It's a success story. The pacemaker. ECG is one of the very nice integration of the e-health is the pacemaker technology, where you have this heart and electrical signal mimicked. Now, what is happening here? You are having electrical signal and embedded in heart. But where the AI comes, the software comes, here you can see killed by the code. You can just see here, killed by the code. FDA recalls 23 defective pacemaker devices because of defects. But the thing is, it's a very important lesson for us that sometimes higher technology, if the software is problematic, it can lead to a lot of problems. which may include death. This is another thing. When ECG was coming in a big databases of ECG, people thought, okay, why don't you use ECG? Why don't you use ECG for this thing, for biometric purpose? And what happened was, they found out that there is a chance of attacks because there is a possibility of impersonalization of this kind of ECG signals. So this is another important part, that when you go for AI, the chance of security breach is also higher. So this you have to think about the cyber security part of the e-health, because moment you have more access to health, more insecure will be it from the cyber attacks. That is, someone can probably take a kind of access to your health conditions. So then next I'll talk about the data silos. A data silo is a collection of information in an organization that is isolated from and is not accessible by other parts of organization. It's called data silo. It's something like a container. Now, removing data silos can help us in getting the right information. And you can save money by reducing storage cost for duplicate information. And I'll go to the thing. I'll just mention this one, that we can have what is called the blockchain in healthcare. The blockchain in healthcare is what is inspired by the silos. So we can have Synaptic Health. Then these are the different companies who are using blockchain for healthcare. And this prophecy is the blockchain next dramatic innovation in healthcare. So blockchain will be is likely to be the more dramatic innovation in healthcare. Now, what it is, how it is going to help both for payers and for providers. Blockchain technology is going to help in healthcare, because people will find easy to find out the right sources of this healthcare, and people will have to pay less because they are more connected, so they can share the resources. So this is a better way of. So for patients, you have the better decision making, better, and for improved claims. So for example, health, LIC and all that, also it will be easier. And for industry also, you have a blockchain platform, so you don't have to have a repetitive things. If someone is good in, for example, scan and MRI imaging, someone can be good in cardiac, they can combine to have a chain like this, so that they can have a kind of distributed partnership model. So they don't repeat the resources. So this is shiny applications. Not get into this. Now I'll quickly quickly change this and so I'll end this lecture by what is called a data tour. I'll just share the screen again. Probably there's some problem with the sharing screen. Am I visible? Hello?
Sir, video is visible, but the PPT is not showing.
It's not visible.
Something happened in between. Okay, I'll just see.
So kindly reshare it.
Okay.
Yes, sir, now coming.
Yeah.
Is it coming?
Not yet.
Not yet, sir, but it is coming. Started.
What happened? Okay. Yeah. Is it coming?
No,
Can you see
yet.
this?
It's not showing. No,
Not showing?
no, no,
No,
no,
sir.
no, no.
Okay.
It is
Okay.
written that started but not displayed.
Sharing. I'll stop share and again share. Okay.
Yeah, you can try, otherwise do some other.
Share. Is it coming?
Yeah, now it is coming.
Yes, sir.
Okay. So I'll just quickly visit. So I am almost in the last of my lecture, some of the sites, because I say it is a tour of data. So this is what telemedicine is all about. Okay. So these are the telemedicine companies, very interesting companies called Teladoc, MD, Clinic, Amwell, MD Live, Doctor and Demand, Live Health. These are a very, very interesting company in telemedicine which have come recently. And then you have what is called Indian Telecommute Company, as I mentioned. This is the V-Health company, which is again very important because it is the first Indian company to start telemedicine in that sense. At least that is what is recorded. Maybe there are other companies which I don't know, but this is, at least on the internet, I could see that this is the only company which they mentioned about Indian company which have come based on in Bangalore again. So these are the two things, and then we have this health informatics, about which our Honorable VC was talking about courses. This is one course which they have already started. AICT approved 2 years full programs of some universities have started. This is about PG, DGHM on health information, HIT is called Health Information Technology. So this is something which is one can start in a typical e-health course. Then there is M-Health, and there are very good articles on M-Health, and I have the good resources here, and you can see this paper, Mobile Health Clinic Model in the COVID-19 Pandemic, Lessons Learned and Opportunities for Policy Changes. So this particular paper came in 2020. So this is a very, very interesting account for how suddenly there is upsurge of mobile health and all that after this COVID thing. And actually, they are saying that it is the most underutilized society, resources in telemedicine. And then we have what is called this evidence-based medicine. I talked about it, and I said that, and this is a paper which says, I'll just show one small pyramid here. You see here, this pyramid is very important. This is the base of the pyramid, is the in vitro test tube research, which we do, most of the biologists do in the clinical lab. They do on cell culture. Then you have the animal science research, then ideas, and then case reports, then case studies, then case control studies, then cohort studies, and then the randomized control studies. By the way, this randomized control studies is something which faced the economist Nobel Prize, the Bengal economist Nobel Prize. This is called random control studies. Actually, it came from the clinics. And then you have the last one is randomized control double-blind studies. This is the top of the pyramid. So these are the way you have. Now, to put it in a logical sense, this is the standard technique for drug discovery in the normal medicine. But what about the traditional medicine? They have totally a different type of algorithm. This pyramid is meant for the normal drug discovery, normal hospital discovery. So one has to think about the system. We have to have a systems thinking in how to integrate the drug in the, for example, the Chinese people are doing it. They're using traditional Chinese medicine, and they are having a new drug discovery algorithm for their own, for justifying their own traditional medicine. Now, this is a COVID associated articles. I'll not show it because I'll share the link. You can see it yourself. This is the Moore's Law in Health I mentioned. Again, I'll not share it right now. Yes. And this is a system dynamics modeling. And this is the least e-health can do. That is, as I told you, that this pulling the COVID data. This is one application which we made using the R. I'll just show you. I want to see a demo, just simple data, what interesting things you can do with simple data. You can see here the country-wise distribution of the COVID infections. If you go to this site, you can see this. See, it is Italy. So if I say India, so you can see it, what will happen in India. So if I say India, India will come like that. So it is different India. You see Andaman, Andhra Pradesh, different thing will come. If we now see what is West Bengal, you can see here how West Bengal will come. So you can see state-wise. So this is called a shiny server, basically R-based platform by which you can see this kind of different type of dynamics of this. Yes. Hello. So I think I have almost come to the end of it. And one more slide. What happened? And I'll skip it. I'll skip this also. I'll skip this one. I'll skip this one. I will just I'll show one thing for your, because this is probably the last but one slide. You see here that this is ECG data and from the PhysioNet. And you can see here, if I run it, you can see here how it runs. This is, you can choose the patients, different patients. And you can see here, these are called RR and these two are PQ. And you can see the same patient will have different RPQ distributions. So this from different thousands and thousands of patients, the database for them is there in this database in PhysioNet. And from that, you can use what is called AI. So we have to have the data first. We don't have the data. As I told you, the data part is very important here. So can AI ever be the doctor? I'll refer to the Penrose, and this is where I end. And I think I probably took a little around 30 some minutes. And this is where, AI and doctor, so it's a kind of superposition of these two probably will make the best management. So this is if we and for the time being we have attention plus sleep. So some people are sleeping and some people are attending this. So always we have a kind of superposition of these two. So this is where I thank you very much. So with that I stop share.
Thank you, sir, for such an informative talk. And in fact, I think you had a lot of, information for us, but I think because of less time, you could not share. But it was very interesting, actually. I believe that most of our participants, they have enjoyed this, actually. This is actually throwing light with, especially the models and other things. So now, before going to the next speaker, whether there is any question from the panelists. There is no question from the audience, participants, but any question, or shall we ask at the end, because it may be relevant now itself for another 2-3 minutes if we can spend, if there is any question. Otherwise we'll move on to the next speaker.
I think you move on to the next speaker.
Next speaker, yeah. So next speaker, thank you, sir. Thank you, Professor Professor Anjan Dasgupta, and because for such an informative lecture. And now we move on to the next speaker, Professor Dr. Pradeep Mitra. He was the former Director of Medical Education and ex officio Secretary, Department of Health and Family Welfare of Government of West Bengal. Presently, he is heading the COVID Monitoring Task Force of Government of West Bengal. So we expect a very, very informative and very enlightening lecture from Dr. Mitra, and as he is very much famous for this, actually, I believe. And so over to Dr. Mitra, please start your proceedings, lecture and sharing your slides. Please, Dr. Mitra, please. Sir, you are muted.
Now I am
Yeah.
audible.
Yeah.
So thank you. First of all, Professor Soigat Moito, the Vice Chancellor of MAKAUT, and Sorodindu particularly, and all the other members, Professor Dasgupta as well, and Prantor, who is almost my student, not direct student, but almost my student, and for allowing me to be present in this important session. But at the very beginning, I must say that I am not that much of familiar with the digital health or the details. Just now we have seen their advancement in the digital health and how it covers a huge area, and it is the future. Artificial intelligence, AI, is the future, as told, definitely. But I will be just going through some of the areas, some of the areas where I can have some comments, because I have a long experience in the administrative setup of the healthcare setup. So I have done, particularly during my, not as the director of medical education, but during my tenure of the director of the IPGM and SSKM hospital, one of the biggest hospital in the country. So naturally, I get some experience over that, working over there. And I was the director for more than 8 years there. So continuous 8 years. So I've seen a lot of changes in the healthcare setup there. So just I'd like to share the screen for my presentation. So if you allow, then I can share the screen.
Yeah, it's allowed. It's allowed. You can just share, click on share the screen.
Yes, is it visible now?
No, not yet, sir.
Oh, I have clicked this.
Sir, there is a green icon at the bottom of the window. From that, you select the application that you want to share, sir, and please click on the share button after selecting the application.
Select the PowerPoint window and click share once again. Otherwise, I have a backup of the slides. I can project it for you, Professor Mitra, if you want that. I can project the slides for you, okay, and you can speak.
You have slides,
I have a backup. I have a backup. Yeah. Otherwise, you can speak. Let us try.
First of all, you run the PPT in your desktop, sir. And after that, only the window will be available, application window in the share option. So open the PPT.
PowerPoint is open on your.
PowerPoint is open.
Okay,
yes,
then now.
So what you say?
The green icon button, sir. Share screen.
Share screen.
Share screen.
Yeah, then you have to select the PPT from that.
Before that, a green icon, yes.
Share screen.
I have clicked that on the.
Now, after pressing green share screen green icon, can you see on the screen your PPT open?
Sir, have you opened the PPT, sir?
I have opened.
Yes, sir. Now you click on the green icon at the bottom of the window.
Just a minute.
Window.
Actually, my connection has gone. That's the problem. Oh, okay. It is coming back. green icon. I have tapped the green icon.
So
Mhm.
now
Share
you select the
screens.
PPT option, sir, from the list of applications. There is small windows for the applications. You have to select the PPT application, and after that, at the right bottom of the corner, there is a share button. You have to click on the share button, sir. After
No,
selecting the PPT application, sir.
PPT application where it is there.
So
You will see
when you
once
click
you
on the share button, there will be multiple windows showing, small windows.
Yes.
In that, you sir pick up the PPT. You select the PPT, and after that, sir, I think connection is lost.
Is it sharing?
Yes, there is share button in the application window that you have selected.
Okay, I'll project it. Okay, no problem. I'll project it and then.
Yes, sir. If Pantha sir has the PPT, then
I'm doing it.
yes.
I'm Korvit. I'll just do it. Yeah. Just a second. Yeah, I'm doing that. Just a second. I'll close the other slides. Then I'll do it. Just a second. Here also it's not sharing. Just a second.
Yes, sir. Sharing it is
Yeah.
coming. Yes.
It's coming, right?
So please select the PPT, sir.
Yeah, I'll just do that. I'm sharing the screen. I'll just pause it and I'll select, just a second. I'll stop share and, oh, actually because Pradeep, we are viewing Dr. Pradeep Mitra's screen. So I'll just, Pradeepta, can you stop sharing so that I can share?
Stop
Yes,
sharing? Yes.
yes, I have stopped, sir.
Okay, you have done that, right. So just a second. I'm opening my PowerPoint again. Okay. Yeah, now I'll start sharing. Yeah, we are ready.
Perfect. It's coming. Yeah.
So, yeah. You can start, Professor Mitra, and I'll be changing the slides accordingly.
Now, I cannot see the slides.
No, they should be on your screen also.
So have you opened the Zoom application, sir?
Yes.
Probably use your
So kindly open the Zoom window, sir.
Yes. Now, shall I go on?
Yeah, you go on. I'll be changing the slides. Don't worry.
Oh. So you will be changing.
Yeah, I'll be changing it. You don't worry.
Okay. Then I'm starting my presentation. So it is in the beginning I want to tell something that is I'll just then I can indicate this one and Pantha you will change the slide.
Yeah.
I'll just point out the finger and then you can change this.
Yeah.
So next slide. So in the beginning, as I told you, that this attempt is limited by imagination of a physician, because I am not basically I am a doctor and physician. I am not an administrator, but I was compelled to become administrator for quite, as in the beginning I told you, for a long few years, almost 15 years. So by that way, I have become an administrator, so I can have some of the areas of the points. So this is the in details of the digital health. Already it has been pointed over the Professor Anjan Dasgupta in details that all the different areas of the digital health, and particularly we'll have to have convergence of the technologies with the healthcare to have the proper effect of the proper complete effect of the digital health. So it will improve the efficacy of the healthcare delivery, and also nowadays, we want to mark the medicine for the more personalized and more precise one for directly to the patient. So these are the, I'm showing some of the system building blocks and the overall goal of outcome. So you have on the left side some system building blocks like service delivery, health workforce, informations, all these are necessary, financing, leadership, and all these four important points are in there. The one is access, one is the coverage, quality, and the safety of the patient. These four, if we can address, then we can reach the overall goal or outcome in a better way. So in an improved efficacy. So next. So this is a busy slide, so you can skip this slide altogether. This also, this linkage of the different areas. So this is important. You see, so in the first stage, you see, then one by one the hurdles are, one is first you will have to identify the pains, what is the difficulties, what are the constraints. So then mindset of the stakeholder. So next is the resource available, then comes the one of the most important thing in our country, that is the red tapeism, and then we need some leadership to do that. And next of all, the very important thing in our governance, good governance, and so on and so forth. In this way, you have to monitor everything. So you have to think on where is the problem, you have to identify first. So next is the next. Yes, definitely these are some problems. This is the first one. Do that, and this way you'll have to the problem you will have to identify the. Yes, definitely these are the closed room, air conditioned room. Just if they try to solve the problem sitting over here, always doing some some meetings and meetings, that will not solve the problem. So actually we'll have to go beyond that. So what is that? So next slide, you see. Only the wearer knows where the shoe pinches. The great saying by George Harvard. So actually, if you don't go downstairs, don't wear the shoe, you can't understand where the shoe pinches. So that's why you'll have to go beyond the, just like beyond the office room, beyond the areas of your administrative block. So every system you have, there are some inputs, there is one process, and there is one output. And fourth one pillar is the feedback. So everything, healthcare system also is moving around this, some inputs, some process, outputs, and then feedback. So inputs means procurement documents, enterprise, organization point of view. Some process means we'll have to use some tools and technologies, and we'll have to hold some meetings, and output is the benefit to the stakeholders. And we'll have to have some feedback from the stakeholders, or who are the stakeholders, I'll tell you in details later on. So we'll have to have some feedback from the stakeholders to go back to the input. So these are the stakeholders. These stakeholders can be many. If there be one person, maybe group of persons, organizations, different. The persons may have those stakeholders. Somebody has got some positive interest, somebody has got some negative interest, and involved in different ways. Money also factors, and these stakeholders are in the community level. These stakeholders may be a political person also. They can also be stakeholders in the healthcare system. So even the panchayat pradhan in the panchayat area, the councillors, everyone may be a stakeholder. So the stakeholders, it is in details that the media people, more elaborate. The government on one side, but the community people, as I told, the positive interest, negative interest. This means charitable trusts. Everyone may be stakeholder. So healthcare is not a multi-touch point. This is not a single point. So multi-touch point is there. So we'll have to be very careful in handling this. Definitely healthcare core group, if you say, that are paramedics, doctors, nurses. These are the but these are our thinking process beforehand. Because but nowadays we know the doctor and patient is not all. We'll have to have more, that is the biomedical engineers, pharmacy, storekeepers, the data entry, data management, data entry operators, the lab technology persons, medical lab technologists. All these are some dietitians, nutritionists. All these different groups of people may be the healthcare providers, not only the doctors only, right? So next. This is, one thing I must say, that one thing I must say, that all these slides have been beautifully prepared by, and all the pains have been taken by Professor Panto Chakraborty in forwarding these slides. And you see all the chief ministers of different states, they're all healthcare receivers. That means we want to say that from the central government, the state is health is a state subject. Often it is said. So naturally, all the Panto has given a beautiful picture of all the chief ministers of different states. Right. Next. But ultimate benefit must go to these down to earth people, these poor people. The healthcare benefit must reach them. Right. Next. So this is how you achieve and how you reach this point. There is ultimately to the Ministry of Health from the public or patients, ultimately health system, different levels, subdivision, district, and then state level, regional level, and then ultimately centrally to the ministry. And not only the health department. Here I would like to stress on that the proper implementation of the digital health, not only the job of the health department, but it is the bioinformatics as told in the previous lecture also. So different ministries must, coordinate telecommunications. Every different ministries must coordinate the, PWD, public health departments, all they must coordinate, and then the proper care will be delivered. Right. So this is also the chart where the importance of stakeholders has been given. That is from the unknown to little importance to serious. Here we have given one. There are different types of persons, but level of influence may be different. Starting from A, that where there is high importance but low influence. These are the actual victims. But if you say the D is the most important part, high importance and high influence, so they can make a difference. These are the persons who can make the difference. Apart from these other two ladies. Next. So after the identification of the problem, next we have to have the mindset. There are two types of mindset. One is fixed mindset and there is the growth mindset. What is welcome? That is the growth mindset. We will have to come out of that. We are the fixed mindset. So then we'll have to come out of that. We'll have to take the challenges that will help us to grow. So we'll have to open. We'll have to be open. So growth mindset is welcome. Next one. So here I have told that 2 reasons why people hate and fight. So next previous one. So people, because of the fear of the unknown, this is one of the most important thing. And there are always people profiting from how things are. So in healthcare, these people are more. They are trying to make some profit out of that. But and also the people fight or hate, that is one for the unknown reasons, fear for the unknown things. So these are important. Next is the why doctors, if their computers actually, these are not actually hated. The present day generation doctors, they don't hate the computer, they're very computer friendly. But the old generations, because here I can make one comment that when in the government of West Bengal we have started the e-prescriptions, and then in some of the departments, we have moved around the different departments, OPDs, we have seen that the young doctors, which are very much friendly with the computer, they accept the e-prescription gladly, while the senior persons mostly they are not very accustomed to it, and they are not, there are some constraints from them for the e-prescriptions. But overall, because computers, one thing is that definitely the software based, but software make us in a structured way. We'll have to go back, but always there is democracy. You can go beyond the softwares and you can create something out of that. Next. So this is a very good picture. You see, when you will be asked who wants change, everybody will raise their hand that everybody wants to have that change. But when you will be asked who wants to change, then the tremendous silence among all the people. So no, everybody wants to enjoy the change, but nobody is coming forward, right? So this is one saying. You see, the most dangerous phrase in the language is it's always been done that way. So this is Greshofer saying, that these are some management Adkar change. So mainly it is based on the awareness, desire, and then knowledge and the ability to perform, and then after all reinforcing it. So whatever is said, we'll have to reinforce that. So right. So this management said. So next is how I try to overcome. Third one is the resource. Resources. There are different types of resources: physical resources, human, intellectual, and financial. Everything is important. All the points are important. Not only the humans, but resource, financial, everything is important. Physical resource definitely important. The space, but nowadays definitely the we can work from home now. What we are doing nowadays, so that is one area. But that is also due to technology. And different types of network. Previously, we used to have some land, local area networks and the connections, but nowadays is the cloud is the best, well secured network, and that is not area based. And data in healthcare most important. So data privacy is definitely another subject. Data privacy is definitely important. Whenever we use more data, privacy must be maintained. So human resource is definitely the key point. the recruitment, not only recruitment, we'll have to train the personnel, we'll have to assign them with some proper jobs, and we'll have to retain them. So most of the time we fail in the retaining the persons, we'll have to this and incentivize. So there is a long saying that particularly in the government jobs, either punishment or incentives. But punishment is sometimes there, but incentives rarely we get incentives for good work. But if it is given, that will work to serve. Not always the financial incentives, even the appreciations. Some sort of just appreciation will encourage them to work more. So intellectual resources, definitely the copyright, all these things will come, the contracts, copyrights, trade secrets, trademarks, we'll have to address all these things. Then comes the financial resources. Definitely, we will have to have some budgetary allocations beforehand, because the which is not in the budget, the one time it may go, but later on, if there is no budgetary allocation, we will not be able to procure things. And then nowadays, government is also, particularly the government is also keen on having some relationships with the industry, and they are going for the PPP, private-public partnership models in the providing the healthcare. This, in a particularly government side, mostly red tapeism, but we have been able to overcome that to some extent. This picture reminds me that when I was the director of the IPG Minister scheme, I started their electronic health records first, and it is about 8 to 10 years back. But up till now, still there. The other medical college except IPG Medicine scheme, these electronic health records has not been implemented. So they will have to, search around the huge amount of, volumes of, bundles of bedhead tickets to find out some information. So now digital file tracking, our system is on that, but later on we have started the e-office. Nowadays we are using that, and most of the departments of the state government is using the e-office and the paperless definitely, and immediately we can see who has given comment at what particular time, how much delay is there, everything is noted. Whether the file, there's no question of pending the files as it was there in the different departments. So e-office is very helpful nowadays. The West Bengal department OPD tracking system and management system also, we are doing that in the OPD, and we can track that. The legal implications always, it is another important area. So we'll have to plan accordingly. We'll have to see everything. We must have, as my suggestion was there in the health department, in providing the proper digital healthcare, we must have a cell, legal cell, who will look after the different legal points. Because now right to information, there are different Consumer Protection Act. It was there, but nowadays it has been changed a little bit. But all these Human Rights Commission, all these will have to answer. So legal implications will have to see. National Digital Health Blueprint, you see, these are definitely they're best formulated. Ministry of Health, already they have formulated a digital health blueprint. So you'll have to go through that. So, digital health program, national one, domain principles and technology. So these two areas, left side, health and wellness. We have some health and wellness clinics also nowadays, and these architecture, these will have to be tied up together for proper implementation. So technology and knowledge. So now you see, this is the most important, leadership. Leadership is not a very easy thing. You'll have to find out people. This is you have seen in the two pictures before, and now the third one. Who wants to lead the change? And the whole hall is empty. So naturally it is, but it is not that, devastating. You will have to find out some persons. Every person has got some power, some power within himself. So you can, just you will have to be motivator, and you will have to find out the power in them and empower them with some, or entrust them with some proper job or proper responsibility. Definitely the leadership will come up. So if we can empower them. So this is, I will have to identify, just as I said, you will have to identify leaders from the people within yourselves and this. So then comes the governance. Governance, is digital health governance. It encompasses everything. The accessibility is, it must be transparent one. The reproducibility, confidentiality, participatory, must be participatory in nature. So good digital health governance encompasses everything. Equitable, it must be equitable, and all these things. So this one. So you will have to moving towards from the polycentric to the patient-centric governance. So you will have to have this patient-centric governance. You'll have to identify this and transform. You'll have to transform. So this from left side to right side, this hierarchy, it must be as evidence medicine, as you have seen, and also the patient-centric approach. You'll have to have that. So next one is the monitoring and evaluations. These everything you'll have to evaluate whatever you can give. But in the beginning, I told you that evaluation or feedback is always necessary to have the change the input. So if you consider a health system, then input, process, output, and evaluation are feedback. So taking the points from the evaluators, you can change the inputs accordingly. So these are areas. So intervention, maturity, life cycle. So I told you these points. Evaluations is most important. Then usability, feasibility, economic and financial evaluations also is needed, and effectiveness, and everything is needed, and which can, strengthen the process of the service, or we can strengthen the need of the proper healthcare, or directed healthcare. Then you can see you have some criticisms also. You must be bold enough, because if you don't accept the criticism, if you think that whatever I have done is good, that is right, so then you cannot proceed, or that the system will fail. So we'll have to be very careful to accept the criticism, definitely, or not always the positive one. You must have some negative feedback also. So you'll have to assess, or you'll have to balance it. So this complex to in a more organized thought process, you must this is a transitional, most organized thought process you will have to go. So naturally, so concerns are there. So bottleneck in the beginning, I told you that the concerns, definitely data privacy, concerns are loss of jobs, surveillance, system errors is another important thing, because always there is you must have some sufficient backup whenever there is system error, or sufficient people to overcome these immediate system errors. Every system that has got some drawbacks, but you'll have to have that. So you see the health content, digital interventions and applications, everything, foundation layers, one by one. Already you see, to make the people, or utilize all the peoples, and application of the technology, and make it is a proper e-health stack platform, and all the legislations you'll have to carefully judge, and then you transform into the utilizing proper infrastructure, you can transform into a good practice. So this is how you can improve the efficacy, and how you can improve the quality of the healthcare by moving step by step. So this is very important. Or while addressing this, we must keep in mind that we'll have to match the demand to the capacity. Firstly, in any setup, you'll have to assess the patient workflow. What is the average workflow? Then according, because you are considering, say, for 50 or 100 patients, suddenly you have, say, 1,000 patients. So your system will fail. So naturally, you will have to assess beforehand what is the demand, what is the capacity, and you will have to match the resources with the unscheduled demands also, so in the end, I want to say you'll have to manage the different variations also in the healthcare, because each source of variations, like clinical variations, like flow variations, all these are additives. They are not canceling each other, but you'll have to have the knowledge of the different variations, and we'll have to address that, right? So kiss means keep it smile and sweet. This is a slide given by Pranthar. So, right. So I say we have some experience, but I have finished it within, say, 35 minutes, as I was told to finish it that. So you may have some experiences or some chatting or question answer. I am ready.
Okay, thank you, sir, for a very, I think, judiciously pointed out a lot of, I think, issues regarding the management of digital health. Actually, if we have to introduce digital health, so far we have been considering digital health from technological point of view, but you have raised this that without the proper management system, the digital health cannot be implemented. That is absolutely correct. And in case of health service, it is much more, I think, critical that the management issues actually have to be addressed very sincerely and very judiciously. So that is our very, I think we got a lot of insight. But we have another problem, because I think there is no question as such, but panelists, if they have questions, they can ask. But we have also shortage of time, because immediately after this at 8 o'clock, I think we have another webinar. So for that, that's why instead of going to detailed questionnaire, I will just go to Dr. Pranthar Chakraborty for summing up today's sessions, actually deliberations, and to reach a concluding state, so that we can have and also this is the last webinar of the series. So he can conclude that what is our takeaway from this series, and how we get benefited from from this series itself. So please.
Yeah, thank you. Can you see my screen?
Yes, we can see.
Okay. So, first of all, I would like to thank the authorities of the university, especially the Vice Chancellor and his team, because I thought, whenever I have discussed this, that there is lack of awareness also about digital health. So devoting about 6 hours for digital health and public health, I thought it was a great gesture, and announcing a Center for Digital Health today, it has taken my heart. So what I will do is, I'll do something different. Instead of giving you a summary, which you can always perceive in your minds, I'll give you a vision for MAKAUT as to how a Center for Digital Health can work for humans who are actually analogous animals. So we have already understood that digital health is of so many things, and it cannot be in isolation. So the most important aim, as I see it today, is to reduce the pain in healthcare delivery. And everybody is facing the pain, the providers, the receivers, and the funders. So even the government, the insurance sector, so everybody knows that the shoe is pinching. We have to understand that how can MAKAUT play a role here. So most of you would be knowing it, but I would be looking at it purely from a SWOT analysis. So if I look at the strength of MAKAUT as of today, again, we talked of the resources. I'll talk of 4 main resources which give the strength to MAKAUT. One is physical. So we have already told you that we have a 40-acre campus, but we would be operating from Kolkata. And I can tell you, be it there where the All India Institute of Medical Sciences is coming up, or in Kolkata, we have access to so many healthcare facilities, because you cannot learn or teach digital health in a closed classroom. You have to look at the system. We don't realize that healthcare is a system. It already has 194 colleges, so many UG programs, and 179 PG programs. But I went to the website and I looked at the list of 6-month certificate courses, right? And if you look at it from the digital health perspective, so many of them are so important. So the university is already playing an important.
আমি আসলে একটা ম্যাকআউটের একটা লেকচারে রয়েছি এখনো 8টাতেই শেষ হবে তোর ফোনটা দেখে
robotics. And so you can understand the way that we can adapt ourselves to empower people who'd like to follow it. Human resources, excellent faculty, large number of students in different disciplines who can interact. You have the advisors that Honorable VC spoke about, and you have the zeal for research. If you go to ResearchGate and if you look at West Bengal University of Technology, look at the total RG score, 783.84. It is no mean achievement. So you can be sure that the people already are oriented towards working. If you look at the intellectual resource, you already have in place an incubator, that is ECTA, which can incubate the startups, because it's not important that you learn everything. You develop your skills, but you learn at least what are the basics of the other disciplines, so you can do interdisciplinary work. You have a motivated team. If the VC himself leads and says there will be a center for digital health, it will happen. And as you came to know, the policy has already been drafted and the budget will be allotted. But what are our weaknesses? Now, being an outsider who has just come inside, I feel the most important weakness right now we have is an identity crisis. You know, that what is the relation between West Bengal University of Technology and Maulana Abul Kalam University of Technology? And that, I think, we will solve it, and people will come to know, and our rankings will improve. We do not have a brand value of our competitor. I'll show you one of the competitors. We have to improve our health university partnership, because health university is again another domain. The national education policy has actually given some insights as to how to do it, and we have to raise the awareness amongst the implementers, without whom we cannot implement it. Now, is there an opportunity in digital health? We have been speaking from the very first day. The global digital health market was valued at $144 billion US. It will grow to $200 billion. So annual growth rate of 27.7%. It is more than any industry in the world. And health technology sector, look at Deloitte, McKinsey, or IBM. So by 2020, medical data will double. They said will. It is actually doubling with COVID, and COVID-19 has accelerated telemedicine. So when I discuss the eras of, sorry, again, So when I talk of the eras, we have already entered the era of awareness, learning, and scaling. So we have to seed innovation. We have to do digital health well. So if we don't do it, others will do it, and we will lose the opportunity. And it's a question of scaling up and how well we do it. as we move from disease to prevention, with internet, with genomics, with social networking, we have to be the pioneers. Some of the blueprints are already there. This is National Digital Health Mission, which will be an independent authority like UIDI. But what are our threats? And I'll end within 1 minute. See, this course is there, an advanced certification program by Indian Institute of Science and Talent Sprint. Do you know how much they're charging? They're charging you 2 lakh Indian rupees plus GST. 6 months, only on weekends, that too either Saturday or Sunday. And when I went into it, you know who were the faculty members? Very respected faculty of the Indian Institute of Science, but all of them either have experience in imaging or in data science. There is no one to look after health system. There is no one to look after IoTs, no one to look after robotics, no one to tell you about design thinking, which is an essential component. No one to tell you about what is entrepreneurship and how you can incubate a startup. So do not worry for the threats. We won't teach. This Center of Digital Health will empower people, be it startups, be it organizations. And if we think of, if we start a master's course in 2 years, we will inaugurate it, as you heard, within a few weeks. We can start short certificate courses. First quarter of 2021, we can have an advanced certificate course. And then we can have a digital health summit. We were supposed to have an artificial intelligence summit this year, which obviously due to COVID could not be held physically. But when we do brainstorming with whatever we have done and we get the task together, in 2022, we will be ready for the health masters, and we can start with research and industry partnership. So maybe in 2023 or 2024, you will see our imprint, that is MAKAUT's imprint on the digital map. Thank you. Thank you very much.
Thank you, sir. It was very, nice actually, because you had taken care of so many, the characteristics of MAKAUT, and you have drawn out, a very detailed planning, and also compared very renowned institution where we have got ages and over them, because we have got so many areas already started. Okay, so I think we are running short of time. Now I will, with permission to, from Honorable Vice Chancellor, I will request Honorable Vice Chancellor to have the concluding remarks before Professor Ananta Das goes for the vote of thanks. Sir, please.
Okay. Yeah, I think we are running short of time. People from next webinar, they are continuously calling. So it was a very wonderful discussion. And Dr. Pranta Chakraborty drafted a SWOT analysis of this for this university. This is very important. We need to work on it further. The thing is that regarding establishing our brand and making it more visible, yes, definitely more exercises we have to take up. And already we have started different activities like strengthening our social media our platform, our brand promotion activity using different partners and professionals. That has already been started. So let us now start working in this direction. So now we need a micro detailing of all these things. Perhaps maybe by before 10th August, we can find a suitable date for again maybe a meet for us along with our all stakeholders, our faculty members, our officers, our all affiliated institutes, and all these things to formally declare this this activity, and then we can launch the programs. And beforehand, before that, we need to now decide to which programs we would like to run and what would be the decision on the course structure, course fees, syllabus, and all these things that is to be decided. then different partners with whom we will forge strategic alliances, that this will be required. And those who will be in charge of the operation and all these things, we will be deciding that. And in between, we can have more interaction with Dr. Panta Chakraborty and Dr. Sarodin Chakraborty and Dr. Pradip Mitra to seek their advices to make this planning more, this elaborate and details. And I believe that it will be a successful, this venture from this side, because at this particular this side, India, this Eastern India, maybe in Odisha, some projects or programs they are planning to initiate, but not yet been started. And one of the good thing is today Times ranking, this out of 13 engineering institutes from Eastern India, the institute associated with us are 18 numbers. So that is a good sign for us. This is one of the one of the fact that has been recognized, that this university all are this affiliated with MAKAUTs out of these different engineering colleges and institutes who are ranked in Times in ranking. So the brand is slowly and certainly this is establishing. One of the problem was there, the change in name and all in between. In 2014, this university's name was changed, but that is an historical fact. We cannot do anything to reverse it. But however, this now we have to put all our forces together to make this brand more visible. Maybe within perhaps Dr. Dasgupta and others can say that within the last 3-4 years, our visibility has increased to some extent. Now, there is no questions of complacency and satisfaction. We want to work further, work hard, more hard to make it more successful. Digital health, that will be this one of the flagship project in that direction. With Health University, we are exploring the possibility of collaboration. Dr. Pradip Mitra is there. He will be our this main this resource person for bridging the link between bridging the gap between this Health University and our technological university. And we can have more discussion with Dr. Mitra, Pradip Mitra, and kindly think how we can have some collaboration with them. And you are there always. So
definitely. Actually, we have already started. Am I audible?
Yeah. Yes.
We have already started discussing, and there are 2 or 3 meetings have been already done. So definitely this platform, this webinar series, these 3 days, 6 hours is definitely helpful, and it has given some area of interest or area of further thinking how we can proceed. So naturally, we can sit together, we will discuss, particularly in telemedicine. Definitely there is a lot of scope. Government also in this COVID situation, also government is totally relying on that. Government has developed some the phone number, and if you call it, the doctors are there who are given advice over telemedicine. So to popularize that, not only in COVID situation, in other cases also we can utilize that telemedicine. We can develop that. There's definitely one area of improvement, scope of improvement is there. And there are so many other areas, AI, and particularly this ECG. Already Dr. Dasgupta told that how we can utilize the different ECG testings with the AI, artificial intelligence, and utilize we can store that tracings, and we can another area is definitely ICU monitoring. By mobile apps, the consultants can go back home, and from home they can monitor the beds and the different patients ICU monitoring. So there are a lot of areas where we can digital health maybe of tremendous help in present situation.
Thank you, Dr. Pradip Mitra. We are planning to apply to different funding agencies also to receive some grants and funds for taking up certain projects in a collaborative manner. So we'll work on it, and Saradindu Chakraborty, Ananta Das, Dr. Dasgupta kindly make a format for this making this planning more executable. So with this,
Okay.
I would like to thank to all of you for taking serious interest in this project, and we believe that we'll in a joint manner, in a collaborative manner, we will make it successful. Thank you.
Thank you, sir. So, Professor Das, it's a request, it's a very fast, vote of thanks. Okay.
Yes, sir.
Because we have
Yeah, we have
program on
another-
digital marketing, and the resource
Yeah.
person is from UK. He is calling. Today I had this is seventh is coming.
Yes, yes.
Seventh webinars.
see.
From the morning 9 it started.
So let's thank our Honorable Vice Chancellor, Professor Dr. Shoikat Moitra, the eminent speakers, Professor Dr. Anjan Kumar Dasgupta, Professor Dr. Pradeep Mitra, and Professor Dr. Prantar Chakraborty, our respected directors, heads, faculty members, students, and other participants of our university, other institute, other universities, and other organizations. On behalf of the organizing committee, I express my sincere thanks to our Honorable Vice Chancellor for a wonderful, motivational, inaugural, and keynote speech, and a continuous, enormous encouragement, support, mentorship in organizing these webinar series, and also in all matters to the academic development of our university. It is my great pleasure and privilege to propose a vote of thanks on this occasion. First of all, I acknowledge the consent of our Vice Chancellor, sir, and webinar committee for organizing this 3 days webinar lecture series, which has started on 27th June. I am especially thankful to Professor Anjan Dasgupta for your wonderful and absorbing presentation and elaboration on the topic conducted data tour in the digital health domain. Sir, you have nicely explained the relationship between the e-health, ICT, and data sciences. I must mention my deep sense of appreciation and thanks to Professor Dr. Pradeep Mitra for sparing yourself 22 hours valuable times with us in spite of your hectic schedule. Sir, you have given a lucid and lively lecture and presentation on the topic implementing digital health, removing the administrative bottlenecks. Your lecture has enriched us with a lot of knowledge and information on the digital health management. You pointed that digitalization is the health sector has become a must, and it has to be implemented and adapted despite administrative bottlenecks. My sincere gratitude to Professor Dr. Prantar Chakraborty. Sir, I thank you because you had with us despite your extremely valuable time in all 3 days, and you enriched us with your profound abysmal knowledge and acumen in health sector. Your lively short presentation, sum up lecture has made us spellbound. I, on behalf of webinar organizing committee and the entire team behind the program, and on my own behalf, extend a hearty vote of thanks to all the panelists for sharing us with your valuable and important findings and opinions. I also extend my thanks to administration and all officials who took responsibility for communication, invitation, technical supports, and all other arrangements to complete this organization seminar successfully. I convey my heartiest thanks to system, especially Prem Kumar and Manoj Ghosh for perfect logistic support and guidance, staying behind the screen throughout the program to make all these 3 webinars successful. I heartily congratulate to all the participants for their active participation in the events and patience hearing throughout the session, and also for participating in discussion question answer sessions. I extend my thanks to Professor Dr. Shivamaya Dasgupta, Director, School of Engineering Sciences of our university. Sir, you have accelerated all 3 webinars as a moderator with your beautiful dynamic skill and art. Last but not the least, once again, I must acclaim and congratulate Dr. Saradindu Chakraborty, West Bengal Education Service, Higher Education, department and program coordinator, who had extended his utmost cooperation in framing and organizing this 3 days wonderful webinar lecture series with wonderful and eminent speakers of national and international repute. It was really a hard task for us to get the consent of this eminent speaker to share their experiences in our webinar program and platform. These
Okay,
webinars.
Dr. Das, now conclude. Thanks to all.
Okay, thanks all.
Thanks to one and all.
Yes. Before closing, I'd like to call it a day of.
Because people are waiting. They are other webinar. They cannot join.
Okay. Thank you very much, sir. Thank you. Good night.
Thank you.
Good night.
Thanks to one and all.
Okay. Good night. Good night. Good night.
Good night.